Thank you, and okay, very good. I now have a laser pointer. And thank you to the conference organizers and the local faculty for allowing me to come to India, to beautiful Chennai, and share some information with you. I hope that what I have to present today will be of value. And there we go. As my introducer said, I worked for many years at the Mayo Clinic in Rochester, Minnesota. I'm currently in Indianapolis in Indiana, which is smack in the middle of the United States. For those of you who are interested in geography. You know, it's very challenging to think about even talking about basic principles of neuropsychological rehabilitation in just a half an hour. So what I hope to do is maybe set the stage that myself and the other faculty can fill in as we go through the next couple of days. But you know, when I was challenged really to think about what the basic principles were, this is what I came up with. Here to begin with, I think that the rehabilitation process needs to be based on a standardized interdisciplinary evaluation. Now, I'm using the word standardized a little differently than Dr. Wilson did this morning, and I just want to be clear about that. When I talk about standardized, I'm really talking about any process that is done basically the same way from patient to patient, and that is referenced to some kind of normative data. So that of course refers to neuropsychological tests, but may also refer to any number of rating scales, questionnaires, and other processes, again, that are done in a consistent manner from patient to patient and are referenced to some kind of normative or other reference data. The reason I think it's important to do things in a standardized fashion is the reason that we do things in a systematic and standardized way in any industry. It's for quality control. It's in order to learn from our mistakes and be able to compare across cases whether we're doing on the right track or not. You know, to be a little more specific about that, what that evaluation might look like, and again, Dr. Wilson was fairly comprehensive in her description this morning. But you know, again, just to emphasize a few points, more than anything else, it should be holistic. And from what I understand from India culture and society for many, many thousands of years, the concept of holistic is hardly a foreign one. You know, what that means is that we pay attention to the whole person, physical, cognitive, emotional, spiritual, social, as well as the environmental factors that impinge on them. So the person in the context of their environment. It's based on functional evaluations, as well as neuropsychological evaluations, and we heard again this morning some about the challenges in doing a neuropsychometric evaluation with some populations. So again, perhaps the fallback position is to really emphasize the functional and thoroughly evaluate how whatever problems, strengths, and weaknesses may occur after brain injury are evaluated in the context of the person's life and how they either assist or detract from their ability to function in their lifestyle. As I mentioned, it identifies both strengths and weaknesses. Something that I'll use as an example, especially in the case presentation, is an instrument that I developed over the years with Muriel Lezak, the Mayo Portland Adaptability Inventory. Certainly there's other ways to do this, but this is an instrument that's very familiar to me, and I think can help guide a relatively thorough assessment in planning for rehabilitation. You know, once we have a conceptualization of the case based on our evaluation, and I should add here, I was having a conversation at the coffee break with one of the participants, and I was talking about how it's rare, I think, in our business of rehabilitation to completely and accurately conceptualize the case before we begin. My experience over the years has been that one does their best to understand the case before beginning the rehabilitation process, but there's always surprises. One always learns more about the patient. And in fact, if we're doing things right, the patient is changing. So in a sense, we need to constantly reevaluate and re-engineer our rehabilitation process to suit the patient as they are developing into a different and hopefully more functional person. In the context of that process, we begin to set goals with the patient and in some cases with their family. That goal setting should be collaborative. It should not be us giving them goals. It should be us understanding what their goals are and working towards those mutually selected goals. So in a sense, it's a negotiation process. Some of you may be familiar with a Western writer, Stephen Covey, who talked about the 7 characteristics of highly successful people. This has nothing to do with brain injury rehabilitation, but one of his key characteristics was that very successful people begin with the end in mind. And I would certainly encourage all of us to do that in working in rehabilitation, to try to understand with the patient and their family, what is the what is the end? What is the goal? What is the ultimate place that they want to be as a result of our rehabilitation? And then work backwards to develop our rehabilitation program. In most cases, it has something to do with community reintegration, getting back to full functioning in the community and in family life. And then, more specifically, what does that mean for the person in terms of who they are and who their family is to get them back to the lifestyle that they have chosen prior to their injury. These goals, of course, should be positive outcomes valued by the patient, not by us. I was talking with someone else at the conference about a case that was very formative for me early in my career, where I was working with a young man to develop some memory compensation techniques. That was my goal, was to improve his memory. As we proceeded, and he really wasn't doing very well in memory rehabilitation, I asked him, what the problem was, why things weren't going so well, and he just told me, Doctor, my memory is not that important to me. It's never been very good. I don't expect it to be very good. What's important to me is the fact that I have a lot of hip pain that's really interfering with my life. So we gave up on the memory rehabilitation. We pursued his goal of working on his hip pain, and things went much better. He returned to a very active lifestyle, a very rewarding lifestyle. Again, his goals, not mine. Important lesson learned early in my career. Another thing that we have done traditionally, at least in the States, is when a patient comes to us is to develop a fairly extensive laundry list of the disabilities that have been sustained because of the brain injury. Neuropsychometric testing can be very helpful in that, since it identifies exquisitely all the neuropsychological disabilities that people may acquire because of a brain injury. However, I'd encourage you not to do that. Well, let me modify that. I think it's important for us perhaps to know the person's strengths and weaknesses, but it is not our job to remediate every disability that they have if indeed it interferes in no way with their lifestyle or their end goal. Again, I offer the example of my young man with a memory disorder who really had no problems with his memory disorder. Also I ask you to think about your own careers and your own advancement in your profession. I know for myself, if as I had started college, I had made a list of all my weaknesses, I probably just would have committed suicide rather than continue with my education. So, again, I think focusing on weaknesses is, again, good for us to be aware of our patients' weaknesses and their strengths as well. But we don't need to remediate all of them. What we need to do is help them either fix or compensate for the ones that are interfering with their goal, with the end of the process. The goal-setting process itself can be an intervention. In fact, there are executive function interventions that are oriented specifically towards goal setting, and we'll talk about a little more about those hopefully later in the symposium. I've been emphasizing the idea of the end goals or the ultimate goals of rehabilitation. In approaching those, we may identify any number of step goals, or smaller goals that advance towards that ultimate goal. A tool that's been helpful, I think, in developing goals and goal setting is called goal attainment scaling. Again, I'll describe that a little more in a few minutes, and in the case study. Basically, it's just a less black and white way of setting goals. So rather than simply setting a goal as achieved or not achieved, it gives one the capacity to look at a goal as almost achieved, solidly achieved, achieved beyond expectation. Again, a little more real life, where goals are seldom achieved either in a black and white fashion, but more in a graded fashion. Now, once we have our goals, at least in broad brushstrokes, we can develop a treatment plan based on those goals. In my estimation, this is best done to a transdisciplinary process, meaning that all the providers involved are engaged with the patient and family in developing the plan to suit them and to pursue goals that are relevant to them. I was struck this morning by our keynote speaker's comment about wanting to do something more than her smile could achieve. And I understand that. I think it's important for us to find techniques and interventions that are a little more powerful than a smile. But I would also offer that smile may be a critical, and in fact I believe is a critical and very salient factor in any rehabilitation or other psychotherapeutic treatment. In the psychotherapy literature, and more often these days in the rehabilitation literature, we find talk of the therapeutic alliance, which means not only the smile, but the relationship that we develop with our patients and that our patients develop with us. That relationship is an important, if not critical, factor in encouraging the motivation and the rehabilitation process. And some people would contend is perhaps the most important factor, the most powerful factor that we have both in psychotherapy as well as in rehabilitation. Now again, that doesn't diminish from the more technical kinds of interventions that we offer, but it, I think, is a necessary and perhaps not sufficient condition for therapeutic change. As I mentioned before, the process of treatment involves regular reevaluations. We're not dealing with a standing target, we're dealing with a moving target, wherein goals and plans may need to be revised as the patient progresses, as their goals become more clear to them as well as to ourselves. Our treatment plan needs to include planning for generalization outside of the treatment arena. We know that people with brain injury can often learn quite well in a structured environment, master things in a structured environment that then do not translate into the real world or even into another structured environment. So we need to plan for that difficulty that people with brain injury have in translating and transferring learning from one situation to the next, and give them practice in those other situations in order to encourage that transfer. In brain injury rehabilitation, there's generally an emphasis on procedural learning. So again, with the deficits that are so frequent in semantic memory and declarative recall, the emphasis is more on learning by doing. And I assume that most of you are familiar with the difference between declarative and procedural memory. Declarative memory being the ability to remember things in more verbal or other symbolic kind of encoding. Whereas procedural learning is learning by doing. It's learning how to swim, it's learning how to play tennis, it's learning the route from your office to your home, which most people after a number of trials can basically do in their sleep without guiding themselves in words. And in fact, some of you may have had the experience of someone asking you for directions to your house or another familiar place from someplace else in town, and you may tell them, well, I can't tell you how to get there, but follow me because I can show you. Because again, the route is ingrained in your mind, but the street names and all the turns are not. Again, the difference between procedural and declarative memory. Because of the obvious deficits in declarative memory after brain injury, rehabilitation tends to be more focused on procedural learning. It also involves the strategic use of learning, helping the patient learn new things, versus intervening with their environment. Some people, particularly with those with severe brain injury, are simply not going to be able to acquire all the information or all the new skills that they need to function successfully. So there may need to be significant environmental modifications, both in their physical and their social environment, in order to support their successful functioning in those environments. I'm no expert in medication, but the medications can be helpful in many cases, and it's good to have an expert on the team who's able to recommend those medications. Just in a very gross generalization, in general, I think medications that enhance neurotransmitter functioning, stimulants, SSRI, serotonergic stimulating medications are the most helpful. Those that suppress neurotransmitter functioning or brain functioning, like the major and minor tranquilizers, are not very helpful. We talked a little bit about the importance of generalization along those lines. Trials in work activities in as real world a situation as one can put together. Trials in independent living activities, again, outside of the clinic, I think are critical in order to help people make the transition from rehabilitation to functioning in real life. And as I think been saying throughout the lecture so far, the involvement of family and significant others who are important to the patient and will assist in these processes also a critical component. Let's shift a moment and talk about the team, because I think, so far our focus has been on the patient and their family. However, in working with a difficult, complex case in rehabilitation, the care of the team working with the patient can be just as important and just as critical to success. A team that is working well together will be successful. A team that is not, or maybe contentious, is going to fail. For those reasons, it's important that teams have regularly scheduled meetings without the patient to discuss not only their activities with the patient and coordinate those, but also discuss and reconcile any differences of opinion that they may have about how things should proceed. When I was at Mayo, we developed a number of years ago some ground rules for team functioning. These were developed collaboratively by the team, which included the multidisciplinary group, the social work, OT, PT, speech therapy, psychology, of course, medicine, recreational therapy, a relatively broad group. And these were the rules that we came up with that worked quite well for us. We will periodically review our effectiveness as a team. So we'll think about ourselves. How are we doing? We will not judge, challenge, nor evaluate an idea until we have heard the whole idea. And this came from a number of experiences where people would interrupt each other before they had a chance to fully express themselves. So in our team meeting, we routinely share our entire opinion before it was critiqued by others. We will attack problems, not each other. We will disagree without becoming disagreeable. So again, we're not discouraging discussion and dissension and trying to come up with the correct solution. What we are discouraging is people taking it personally and getting mad at each other and splitting our energies for the rehabilitation process. And once we have reached a decision, everyone will support it, even though you may disagree. If as a group we've agreed to a certain course of action, we will all support it 100%. We will each participate in discussions fully and openly. So, in other words, no passive aggressive. We will not use silence as a weapon. Simply put, no pouting. We will deal with our conflicts and frustrations directly and promptly. We will feel free to bring up problems and invite possible solutions. So again, none of this is meant to suppress discussion. In fact, it's designed to encourage healthy discussion that will keep our eye on the mission of getting the patient to the best possible place. We say nothing about someone else unless they're present. And we will respect each other's work, tasks, and contributions without regard to their titles or status. So, these rules, I think, can be very helpful in developing a healthy team process. As I mentioned, they certainly have served us well. Moving on, in terms of basic principles, as one advances through the process, one has to start to think about the end when the patient may be discharged from the rehabilitation program. And in doing so, it's important to anticipate obstacles, the need for reinforcement and practice in the future. Oftentimes the family is important to engage in additional reinforcement after formal rehabilitation is over. Along those same lines, thinking very concretely about the environmental and social supports that a person may need to continue to be successful as the rehabilitation team draws back from their lives. To the degree that the patient is able to take on some of this responsibility for themselves, this may involve engaging the patient in self-management training, or to the degree that they're not able to manage this for themselves, engaging the family or their significant others in those processes. And then it's probably good to plan for some regular follow-up and perhaps some refresher rehabilitation, some shorter rehabilitation interventions to rebuild skills if they are lost over time. So let's talk a little bit about and try to put some of what I've just said in context by talking about varying programs and philosophies and approaches. We talked a little obliquely about the difference between impairment focus and goal outcome focus rehabilitation. Impairment focus is the kind of focus where one makes a laundry list of all the problems that a patient has and then attacks one by one. Goal or outcome focused is more of a global approach where you look at the ultimate goals that people want to achieve in order to feel fully functional in their lives, and then work backwards to design a program that will get there. In some cases, ignoring potential disabilities that have no impact on the person's life. Again, I would encourage a goal and outcome focused rehabilitation approach. There's also another difference in approaches, and it's a difference between a medical model, which I think may be most familiar to most of us, in which the intervention is really directed at the individual who is ill or injured. In a medical model, our goal is really to fix the person, to rehabilitate their deficits as possible. Another approach is a social model, where the intervention is not directed so much at the person themselves as at the social system in which the disabled or ill person operates. The reason I put quotes around the word disabled is because, and actually this was brought to our attention in the 70s by people with spinal cord injury, to some degree disability is defined by the environment, not by the person. And if you've ever tried to keep up with a very able person or a very healthy person in a wheelchair, you find out that you're the one with the disability as you're running alongside trying to keep up until you reach a set of stairs, and then you're the person who's not disabled. Again, the point that people with spinal cord injury were making was that it's not that the problem is a shared one, that if the steps aren't there, they don't have a disability. If things like phones and tables and shelves are a little lower, then they don't have a disability. However, in the current environment, they do. Now, these two models are not mutually exclusive. In fact, I think in most rehabilitation processes, we may do some of both, and probably should. So to some degree, we may focus on the person, trying to help them become more able to fix some of their problems. And to the degree we can, I think that's terrific. You know, that's what we need to do. But by the same token, in many cases, we will confront some disabilities that are not remediable. And so in those cases, the person's environment has to be changed. And to some degree, and to the degree they're able or their family's able, they have to be schooled in how to help the environment change, encourage the environment to change, and to maintain those changes. You know, another distinction in program approaches and philosophies is the difference between an individual-focused therapy and a more MALU or group-oriented focus. You know, my strong preference is for a group-oriented, MALU-oriented rehabilitation process, although I recognize that's not always possible in all settings. I think, actually, we're kind of fighting this back in the United States because I think there's a general feeling from people who make our policies that individual therapy is better. And I guess, you know, at some level of abstraction, you'd think that one-on-one would be better to one with a group. But I think the point that's being missed is that one-on-one with people with brain injury, in some cases who don't recognize the disabilities they have, can be extremely ineffective and quickly becomes a very contentious process where the therapist is trying to convince the patient that they have a problem that they should be working on. The patient is resisting, and we're all getting nowhere. Whereas in a group process, especially with someone who's fairly adept at managing group process, the people with brain injuries begin to help each other to understand the problems that they have. Again, this was a lesson I learned fairly early in my career, where after, you know, several years trying to convince patients that they needed to work on various aspects of their problems in order to return to work or to their families, and getting nowhere because basically they didn't believe me. I mean, I could show them all my degrees and all my credentials, and basically I was just a guy in a suit who was in their way. However, when I sat a group of them down and they began talking to each other and explaining, and you know, Joe was explaining to Fred that Fred's memory problem was a problem for him because he missed their appointment to go to a movie last night, it began to dawn on Fred that he might actually have a problem and this might be something that he needed to work on. You know, I think a good group process offers people both the support and the insights that they need to get better. You know, in fact, I mean, this is true of all of us. We believe people that are most like us. You know, so if you're an OT, you tend to listen to OTs. If you're a psychologist, you tend to listen to psychologists. You know, if you're, you know, whatever your religion you belong to, you tend to listen to people who go to the same church as you, who vote like you. You know, we listen to people that we perceive to be like us. It's no less true for people with brain injuries. They value the opinion, and they should, of people who are like them, who've been through this. And so again, to use that group process to help people understand and overcome their disabilities can be a very powerful tool. Now, you know, there's, you know, we get back to the team for a minute. There's several different types of team orientation, and let me briefly describe those for those of you for whom this may not be familiar. You know, at one level, there's the multidisciplinary team, where each person on the team provides rehabilitation to the patient, completely independently of the other. So the PT works on gait, the OT works on, at least in the United States, you know, works on fine motor skills, the speech works on language, our speech development, and the psychologist works on their psyche. They never talk to each other, they're all working independently. At a higher level of interaction and integration, we have the interdisciplinary team, where all those people involved do indeed talk to each other. They develop a coordinated interdisciplinary team plan, and you know, as you can tell, that's going to be more effective than working one-on-one completely independently. It's still another level of integration, and to the degree that this can be achieved is preferable. We have the transdisciplinary team. What this means is that all the providers are not only working in a coordinated fashion and with a coordinated treatment team, but they can assume each other's roles as required. So for instance, if a person has an emotional episode in speech therapy, the speech therapist knows how to behave like the psychologist, at least briefly enough to deal with that situation and move it to the next level. And the psychologist may catch up later. And conversely, you know, if the person with brain injury is struggling with word finding in the psychologist's session, the psychologist knows how to be a speech therapist and do the therapeutic techniques that are required to encourage more effective word finding. The reason why that's important in working in brain injury rehabilitation is, again, people with brain injury have difficulty generalizing from one setting to the next. So if they're having an episode of distress in the speech therapist session, it's really not very effective to tell them, hold that thought until you see the psychologist, 2 hours from now. They really have to there has to be some intervention in the here and now, and conversely with the word finding episode. This transdisciplinary approach is characteristic of the highest performance teams. So if you look at team functioning and things like the Navy SEALs or these black ops groups where the stakes are very high, again, each member of the team has a very well-defined role, but they're also able to assume each other's role if one of them's shot or something like that. Now, hopefully in rehabilitation we don't get shot, but there are situations that, some examples I gave, where we need to fill in for each other's roles. I referred a little bit to the importance of the therapeutic alliance. I think in a highly functioning rehabilitation process, that alliance is explicitly developed, so it's not allowed to occur by chance or nice if it happens. The team really works to develop the alliance with the patient, to the extent that in some cases a given therapist may say, I just can't work with this patient, or this patient can't work with me. And there's a handoff to a therapist who may work more effectively with the patient. And I think in a well-seasoned team, that's understood that for whatever reason, some people just don't work so well together. It may have nothing to do with either one of them, but at some point that magic has to happen where people identify and trust each other. And if it doesn't happen, we need to hand off and find a therapist who does work effectively with that particular patient. There's quite a bit of discussion in rehabilitation circles these days in brain injury rehabilitation circles about a top-down approach to rehabilitation versus a bottom-up. The difference here being from the top down, working more on higher level functioning, goal setting, executive functioning, planning processes versus more of a bottom-up, working on specific skills like attention, memory. I think the current feeling, our consensus is that we really can do both and probably should do both. That doing either one may miss some of the impact of rehabilitation. So it's best to be working on these higher level, more abstract functionings at the same time that we're giving people some basic skills to deal with that kind of problem solving. And then you also find that programs vary in the degree to which they include adjunctive or environmental interventions. I think to the degree that it's possible, and understanding that in many settings resources are limited, the inclusion of other resources is optimal. Examples of these other interventions would be things like addressing substance abuse, addressing family issues that cause difficulties in the rehabilitation process, addressing vocational issues, which in my mind is probably critical to actually getting a person back to work, to explicitly address vocational issues. Again, depending on resources, may not always be possible, but to the degree that it is certainly recommended. And so we're doing pretty well with time. Let me pause there for a minute before proceeding to a case. As I understand, we're waiting for questions until the very end, or okay. Well, then let me give you a case example, hopefully illustrating some of these concepts. This case is a composite case, so it actually reflects several different patients kind of put together. And I do that for a couple reasons. One is in the United States, we have a lot of concerns about confidentiality, and so to present a real case is difficult and requires a lot of permissions that can be withdrawn at any time. So it's easier just to kind of make up a case that involves several patients. And the other nice thing about involving several patients is that it's hard to find a case that illustrates all the points that you want to make. So I kind of concocted one that I think does. So let me tell you a little bit about this case. Her name is Shireen. She's a 29-year-old African-American woman living in the United States who sustained an injury in a motor vehicle accident a little over 3 years ago. She was in good health at the time of the injury, no prior history of medical problems, psychiatric or substance abuse, no difficulties there. She's a college graduate, actually appeared to be quite bright. She was a communications specialist prior to her injury in a multinational corporation. She was unmarried. Her mother, at the current time, is a primary caregiver. Shireen was living independently prior to the injury, but has come back to reside with her mother. Her mother is divorced and was divorced when Shireen was 5. She's had no subsequent contact with her father. In the injury itself, she sustained a lower extremity fracture as well as a severe brain injury, characterized by a Glasgow Coma scale of 6, post-traumatic amnesia of about 2 months. She had a single seizure in the emergency room, but no subsequent seizure history. Initial CT scan, consistent with those Glasgow and PTA scores, showed contusions and small hematomas in the frontal lobes bilaterally, however, required no surgical intervention. An MRI about 2 years after injury showed bilateral encephalomalacia in the frontal lobes and temporal poles bilaterally. She's currently on Tegretol, not for seizures, but for irritability and aggression. Her mother feels like that's not very effective, that Shireen's still kind of irritable. I'm going to structure this case presentation using the Mayo Portland because, again, that's something that's very familiar to me in this process of structuring a rehabilitation plan around the Mayo Portland evaluation is very familiar. So if you'll bear with me, I think you'll see the value in that. Just to orient those of you who aren't familiar with the Mayo Portland to that instrument, it identifies a number of very common problems after brain injury and includes 3 sub-indices. The ability index includes a number of physical and cognitive impairments, as you will see. I'll let you read through those quickly. The adjustment index includes emotional and interpersonal factors. And again, I'll let you read through those quickly. The ones in blue also load on the next index, which we'll get to in just a minute. And the final index is really, what in my mind is kind of the final goal of most rehabilitation program, which is to develop a reentry process into the community and family life. And that's the participation index. And participation refers to participation in community and family life. And the items on that index include the simple ability to initiate behavior, level of social contact, leisure activities, self-care activities, residence, meaning independent living activities, transportation, employment, and this can be both paid and unpaid productive activity, and finally managing money. So with those items in mind, if we think about Shireen, let me go through what a treatment plan might be. Again, as we go along here, you may find yourself disagreeing with some of my opinions, and that's okay, because I think in a rehabilitation process, what we typically do is develop our best guess as to what will work, and then we see. To some degree, it's an empirical process. If the planned intervention is not helpful, we have to try something else. So, looking at the first set of difficulties, and I only have included the items from the Mayo Portland in which Shireen showed any level of difficulty on initial evaluation. The evaluation, I should emphasize, was done by a transdisciplinary team, so including PT, OT, speech, psychology, medicine, the usual array of rehabilitation providers. So Shireen did show some problems, a mild problem that did not interfere with everyday activity and mobility. She also showed a mild problem in use of hands, which interfered a little in everyday activity, and a mild problem in motor speech that interfered a little bit of the time with everyday activity. As you can tell, the ratings on the Mayo Portland are functional. So I'll give you a minute to think about what you might do with those problems, and then I'll tell you what my thoughts were. For mobility, really didn't expect any further improvement, even with very active rehabilitation. So no intervention was planned. Same way for use of hands. The evaluation by our OT was no further improvement was expected, so no intervention was planned. Now, on the other hand, in motor speech, our speech therapists did feel that they could make a difference. They weren't sure they could bring the function completely back to normal, but set the goal at lowering the problem a notch to the point where it might occur occasionally, but would not interfere with her activities. You're looking at the next set of potential difficulties. We have verbal communication. Shireen did have a mild word finding problem. However, it did not interfere with everyday activities. She also had more significant problems with nonverbal and pragmatic communication skills. For those of you who may not be familiar with that term, pragmatic communication skills, what that means is kind of the dance of communicating. But communicating with other people to some degree has to do with language, but it also has to do with facial expression, with gestures, as well as with the way we trade communication. So after brain injury, too often you find that people either talk too much or don't talk enough. They have difficulty initiating. They may have difficulty taking turns, so they may not understand when it's their turn to speak. Conversely, they may not understand when it's time for them to shut up and let somebody else talk. So, all those, again, kind of the dance of communication is something that they need to relearn. In Shireen's case, that was a moderate problem. It interfered significantly with her activities. Fund of information, meaning her remotely acquired information, was a mild problem, but really didn't interfere. So she didn't have access to her knowledge base as she did before the injury, but that did not appear to be a major factor in her adjustment. So what are we going to do about these things? Well, with word finding, it doesn't interfere. We decided no intervention is needed. Same way for fund of information. However, the pragmatic communication skills did appear to need to be addressed. And we know that there is some evidence that a social communication group practice in those pragmatic communication skills in a group setting can make a difference. So we added that as a component of the rehabilitation program with the goal of reducing the problem to one where it only interfered a little bit of the time. Again, trying to be realistic in our goal setting. things may not always be able to be returned to normal functioning, but a reduction of that degree would make a significant difference in Shireen's overall participation in her community, and so that seemed like an achievable and yet a realistic goal. Moving on to the next set of problems. Shireen appeared to have a severe impairment in novel problem solving, both on neuropsychometric testing as well as in everyday life. She had difficulty in attention and memory that interfered significantly with her activities, both on neuropsychometric testing as well as in everyday life. Again, in our opinion, all of those things needed to be addressed. So we thought that we would work on novel problem solving through a number of executive functioning interventions, including formal goal management training, engagement in goal attainment scaling. I'll talk about that a little more in just a minute. Again, with the goal of reducing that problem to the point where it only mildly interferes. Again, trying to be realistic in our goal setting. In order to address our attention, we would use a technique, again, that's evidence-based called attention process training. Again, with the goal of reducing that moderate problem to one that is only mild in degree. And to address her memory problem, we would help her learn how to use a memory notebook, develop one that's useful to her, and train her in the use of that instrument, again with the goal of reducing her problem to a mild degree. Now you'll notice in novel problem solving, part of the goal says develop GAS, which stands for goal attainment scaling. Let me give you an example of what a goal attainment scale might look like for this patient. The overall goal is that the participant, Shireen, routinely uses problem solving and goal management strategies to solve problems in everyday life. So these are techniques that we would teach her, and with the goal of her using these in her everyday life. Now again, rather than just evaluate that goal as achieved or not achieved in a black and white fashion, the goal attainment scaling process allows us to grade goal achievement in a little finer fashion. At the present time, Shireen is at the less than expected level, meaning she has not learned and does not use problem solving or goal management strategies. So that's where she can start. Now, in developing the goal attainment scale, we recognize that she could be worse, and that's the much less than expected. So if she would get even worse, she might refuse to engage in any kind of systematic problem solving and just write the whole process off. We hope that doesn't happen. What we hope is that she advances at least to the next level, which is the expected level of outcome, wherein she would learn and use problem solving and goal management strategies in addressing life problems about 75% of the time, although she may still require some prompting to do that. So that's our minimally acceptable level of goal achievement on this goal. Now, what we really hope is that she'll do even better and be better than expected. And that means that she learns these techniques and uses them in 75% of the time without any prompting, completely independently. Now, in our wildest dreams, she'll do even better than that, much better than expected, and learn and use these strategies in addressing life problems almost all the time, completely independently. That would be ideal. But again, our minimally acceptable goal is a little lower and perhaps more realistic. That's an example of a goal attainment scale, and in the context of the overall treatment plan, you notice we're not making up goal attainment scales for everything, but only for what we're perceiving as perhaps the most critical elements for Shireen to achieve in order to be successful in her life. So, moving on now to the next areas of potential difficulty: social interaction, irritability, and impaired self-awareness. In social interaction, as you might have guessed from those difficulties with pragmatic communication, this is a moderate problem. She has a lot of difficulty interacting with other people. And in part also because she's, as her mother describes, irritable, and that's also a moderate problem that interferes much of the time in her everyday activities. And to some degree, her self-awareness is impaired. So Shireen doesn't recognize all the difficulties that she has. She doesn't recognize her difficulties with irritability. And to some degree, she doesn't appear to recognize how severe her cognitive problems are. Although she may have some recognition that the cognitive problems are there. So what are we going to do about these things? Well, again, for social interaction, the social communication group, I think, will be helpful. And we hope that that will reduce this problem to a mild one. It's also an area where we're going to develop a goal attainment scale because it's so important. In terms of irritability, we'll look for medications that may be helpful in reducing her irritability. As you may have guessed, I'm not a strong believer in medication, but they certainly can be helpful sometimes. One of my colleagues, Dr. Flora Hammond, back in Indiana, has a strong interest in medications to assist with irritability and aggression. And some of her research has shown that substances like amantadine can be helpful. I guess I'm not convinced that any of those things actually are the ultimate cure for these problems, but I think they can put the patient in a better place to learn the behavioral techniques that they need to manage their irritability a little more effectively. So, we'll look at medications as a potential assist, but we'll also involve this patient in group and individual anger management training to begin to teach her some of the skills that may be helpful to her in managing her irritability. And then to address her impaired self-awareness, we'll do several things. One is to help her mother learn a little more about her brain injury as well as the patient. Sometimes families can inadvertently support a lack of self-awareness. So we'll assist both of them in understanding more about the consequences of her brain injury. We'll intervene with some formal interventions for self-awareness. Some of these individuals, some of these group-oriented. Tamara Owensworth just came out with a very comprehensive book on self-awareness interventions that I'd recommend to you in getting more detail about these types of interventions. And then ultimately, because one of Shireen's goals is to return to work, we'll do some work trials. And in my experience, oftentimes people don't fully understand the problems they have until they're back in a relatively real life work situation and to some degree hit the wall, fail in order to understand that the problems that they may only vaguely be able to consider are very real and very interfering with their lives. Now, that can be difficult for people to be in those situations. They may, I've had more than one case become quite depressed after they fully appreciate the problems that they have. However, this is done in the context of our rehabilitation process with the full support of the rehabilitation team, and so that when that depression occurs, we can deal with that too and try to make this the learning experience that it's designed to be rather than a failure experience. Moving on here, we're looking at limited social contact. At this point, she has limited involvement with other people, less than 25% of what you'd think would be a normal interaction for a person in her situation of her age. Similarly, she has very limited leisure and recreational activities, again, less than 25% of what you'd expect for a person in her situation and of her age. To some degree, our intervention for social contact will be, has already been mentioned, addressing some of the social problems, primarily communication problems that she has, should assist her in developing new relationships. The social communication group should assist her. It will also involve her in a leisure skills group to help her find activities that she may find of value. And this would include excursions out in the community to practice those skills, to try new things, and hopefully to meet some new people. Again, we're not looking for miracles here, but we would like this to be only mildly limited rather than severely limited. And then family relationships. There is mild stress between her and her mother that interferes with family functioning a significant portion of the time. We look at these kind of concerns as shared ones. So the intervention will involve both the patient and her mother. Will not only be assisting the patient to deal with those situations better, but also assisting her mother to deal with those problems more effectively. And eventually, we'd like Shireen to move out of the house back into a lifestyle that's more independent. That might involve a group home initially before she's ready to move into completely independent living. But at her stage in life, at least in the United States, it's traditional for a person to move out of the home, and that may be the ultimate goal in terms of reducing some of that family stress. I mentioned Dr. Hammond's work in irritability and aggression. One thing that she discovered in some qualitative evaluations of the interactions with people with brain injury with their family members was that it was a mutual problem. That the problem was not only that the person with brain injury became irritable, but their partner or their family members did not respond in a very helpful fashion. So the patient with brain injury might become irritable. The partner, the wife, the spouse, the children would respond with anger and irritability, only making the situation worse. The patient would get more irritable and things would kind of escalate out of control. So the training really needs to occur with everybody involved, not just with the patient. And then, moving on to the more participation items, self-cares was a mild problem, although it did not interfere. She's not able to live independently, requires moderate assistance, and she's unable to travel around town independently. So to address that, our occupational therapists felt that they could improve her self-care to the point of more normal functioning by developing a cueing system. So, we'll implement that. The overall program addressing the cognitive, emotional, and social issues should allow her to advance to a more independent living situation. Although we anticipate that she may require a little assistance, at least, for the foreseeable future. We will train her formally in the use of public transportation. Again, she may need some ongoing assistance from someone at the group home, for instance, in the long run. We'll probably never be able to drive, certainly not in Chennai. I was out in rush hour in Chennai traffic yesterday, and we have a few people in Indiana who are in NASCAR who I think may be able to drive in Chennai, but us other mortal beings would be unable. But even in Indianapolis, Shireen would have difficulty. So we'll train her on how to use the bus. And then finally, money management and paid employment. A couple things. Actually, Shireen can really just need some help with larger financial matters. So, what we'll do is work with her mother in that regard to develop a financial plan in the long term, and then develop some other external supports for helping her manage her money. In terms of smaller financial transactions, she's very competent at this point, and no intervention is required. She's currently unemployed and would like to return to work. Again, several interventions planned there, individual vocational counseling, something we've called resource facilitation. It's a technique that's being advanced in Indiana by Dr. Lance Trexler. And what this means is, very simply put, giving Shireen a vocational concierge in a way who's going to help her address all aspects of getting back to work. It's a technique that we also used in Minnesota and found to be very effective. Again, kind of in a simple way, in my mind, it's simply giving someone the job of getting this person back to work. What we found in our rehabilitation thing, well, I guess was two things. In the United States, we have a network of vocational rehabilitation providers that is state funded in every state. The office of our vocational services department was within eyesight of our hospital. So, for several years, as people would graduate from our rehabilitation programs, we direct them to that office and give them a referral and anticipate that things would be fine. And then at some point, we discovered that 75% of the people never got to the office, that their life was so disorganized by this injury that they weren't able even to make that initial contact. The other thing we found is that when we began to ask amongst ourselves who was working on the project of getting back to work, what we discovered is we all were, which meant none of us were. That sounds contradictory, but it's kind of when it's everybody's job, somehow you think that the next guy's doing it, So again, it kind of brought us the recognition that we needed to make this somebody's job. And that person, more contemporaneously is called a resource facilitator, and their job is to do whatever necessary to get that person back to work. If they need a ride, who can give them a ride? A family member? If not a family member, a member of their church. If not a member of their church, a member of their club. Addressing all those issues, putting them in contact with employers, helping do employer education so the person is able to get back to work. Again, I'm kind of rushing through this in a brief period of time, but I think the basic message I want to give you is that this resource facilitation is not rocket science. It's very practical, can be done by someone with very limited training, who's good with people, and whose job it is to get the patient the job. This often involves, and almost always involves, some kind of practice, some kind of work trials, where people try themselves out in real life settings until they find a job in which they think it will be successful. Our goal for this particular patient is either full or part-time employment without support. With support. I'm not going to go through all of the goal attainment scales that we developed for this patient because of time, and mainly in the goal attainment scaling area. I just wanted to give you the concept of what that's like. Depending on the patient, you may choose 2, 3, 4, usually not more than 4 particular issues or particular areas to focus on heavily, and those would be the ones that you scale with goal attainment scaling. But I hope that gives you kind of an impression of a holistic rehabilitation process for a fairly complex patient, like the one that I presented, and how a standardized assessment may be helpful in developing that treatment plan. Now, I should add, using a tool like the Mayo Portland, you'll notice that it does not identify every possible difficulty that might occur after brain injury. Some difficulties are relatively unique, and if we came up with the whole list, it would probably be, over 100 different items, and that's just impractical to use. So for any given patient, you may have a few additional goals that don't track directly onto the Mayo Portland. But the reason why I'm advocating the use of a standardized approach like this is I feel like when you're looking at the things that most often occur after brain injury, you're not going to miss anything that's critical. You're going to have a good basic treatment plan that you can fill in with these unique or idiosyncratic difficulties that may appear in a particular case. So with that, I'll end my presentation and surrender the podium to our next speaker.